In essence, there are four, which for practical purposes are the main ones. There are a range of new operations. There are variations of those four. There are slightly gimmicky adaptations, but what any patient should really be thinking about is the four main treatments that are available. There's the laparoscopic gastric band, there's the laparoscopic sleeve gastrectomy, and there is the laparoscopic gastric bypass. And of course, there is the endoscopically placed gastric balloon. Now, the gastric band, we don't really do as often these days for various reasons. It's not so easy to live with, a lot of adjustments required, and a large proportion needed removing for various reasons, sometimes inadequate weight loss, sometimes slippage. So the mainstays of the bariatric surgical operations are really nowadays the sleeve gastrectomy and the gastric bypass. Of course, there are variations such as the mini gastric bypass, there is the biliary pancreatic diversion, and so on. But in essence, it is those four. So who decides? Well, ultimately, of course, it will always be the patient. And the doctor's role is to give you the guidance and the support to make that decision. Of course, we're not going to let patients, or no good clinician should let a patient make a decision that's not good for them. But there are decisions, there are choices which are of equivalence. Some have advantages which others don't have. Some have disadvantages, and they can balance out. So it is essential, in fact, in my practice, to give the patient the empowerment, that sense that they are choosing it. In fact, I want the whole process to be patient-driven because I think that gives a better result. The patient's motivated, they come to you eager to get treatment for their weight loss. They will be more engaged, more invested, and they will do better. So the decision is the patient's, guidance from us, advice from us. And generally, someone who has a lot of experience can, after doing a detailed history and assessment, give that patient the best fit. And that's usually how I see it. The operation that will best fit that particular patient. The most important part, this hasn't changed from the day I started medical school several decades ago, is it's all about the history and about the examination. It's really, really essential. Nothing, no test, no blood test, nothing will replace that. A detailed history will give you a great deal of information. You will get to know your patients from that. And it is from that history that you get the essential information that will allow you, as a surgeon, to guide the patient, and it will allow you to give the advice to the patient to allow them to make that choice. So together we arrive at that decision, we providing the information, the patient telling us what they want, and then we will guide them towards the best decision. So the history. Now in that history, there are essential things we ask for, obviously a lot of information. But for example, diabetes. We know that patients with diabetes will do better with some operations than with others. Reflux disease, if the patient has a lot of heartburn, if they're dependent on omeprazole, pantoprazole, we know that some operations might exacerbate those. So we warn the patient about that. And together, we will make a decision if we think that's going to be manageable post-op or not. Age, risk factors. Some patients are just very, very high risk. And for those, we obviously want to go for the lowest risk procedure. We have to balance the risk with the benefit. So amongst those four procedures, mainly the last three, the lap sleeve, the lap bypass, and the balloon, we will make a choice of these or variations of those operations based on the patient's age, risk factors, past medical history, and current comorbidities. For example, if someone has bad reflux, we might advise for the bypass rather than the sleeve gastrectomy. The bypass allows a diversion of the gastric juices, and therefore the patient is not likely to get reflux symptoms and become PPI dependent. Sleeve gastrectomy, reflux is not a complete contraindication to doing a sleeve. You can still do a sleeve in people who have some reflux, but as long as the patient is aware of it, as long as the surgeon takes every step to minimize the risk of reflux and does a proper assessment, it's still occasionally feasible. Sometimes you need a hiatus hernia repair at the same time as the operation. That can be done as well. Some of the lighter patients, depending on their lifestyle, depending on their preference, might want to go for a gastric balloon. In fact, most of the people I place the balloon on, the patients have come to me and they've asked for the gastric balloon. It's not so much me steering them towards anything in particular. It's me eliciting from the patient what they want or what they think they want. I think you need to be clear about your expectations, about what you're hoping to get, and be important before even going forward to make sure that the whole range of options, sensible options, are available. Obviously, it's important for you as a patient to know the outcomes to expect. And in fact, a lot of this is guided by a comparison of the outcomes between the ranges of procedures, between the sleeve, between the bypass, and the balloon. For example, the balloon is removed after 1 year, so people regain weight. For many, that's not a problem. They choose that because they don't want to have a formal laparoscopic operation with incisions. With those people who do want to have the operation between the bypass and the sleeve, recovery time, getting back to normality, I think is key. Asking the doctor when you'll first drink, when you'll first eat. And it's important, really, I regard it as a priority, in fact, that it's not just so much for weight loss, not so much addressing comorbidities, but to get patients to a good quality of life. So they're able to eat and drink with families, relatives, friends, socially go out and about with minimal symptoms. And I in fact, when I do follow-up, that's one of my first things, is to see the functional outcome, to see how people are getting out and about and the impact it's had on their life, rather than just the weight or the blood sugar levels of the HbA1c. So I think is to focus on that. It's perfectly all right, by the way, to ask your doctor about their experience and about their results that they've had. I think that's a very reasonable thing this day and age. So you can't always get that information online. It's not always available, but I think it's a very reasonable question to ask before going through with a very, very major life-changing surgery. How can you prepare for bariatric surgery? Well, I think it's essential to get as many things in place as possible. It's nice to have a bit of time off. I'm talking about a couple of weeks after the surgery, where you can devote that to yourself and focus on your eating and your lifestyle. I do ask patients to clear out the cupboard, to get all the things which are not healthy and the bad habits, to get them out, donate them, just not buy them anymore and not stock up. A lot of us have stuff which is not necessarily the best, sometimes driven by COVID or whatever, when we were stuck indoors. So to clear out the cupboard and get everything in place in terms of their larder and their kitchen and the time off. But I think I will also round off with this. You will never, ever get to the point where everything in life is perfect, where your house move has happened, where the children are at that right school, where the job change inevitably is going to happen, or the promotion or something you're waiting for. And sometimes you just got to get the bare essentials in place, the kitchen, the food, the storage, and a couple of weeks of time off, and then just go for it. In terms of direct preparation, we put all of our patients on a liver shrinkage diet. I've been doing this since 2001. It's essentially a low carbohydrate diet. Makes people feel a little bit better, but also makes access to the essential areas easier during surgery, as the liver can get quite large and fatty in people who are overweight. So we like that to get back down to a normal size. And to maintain hydration. In specific cases, if people have cardiac or respiratory problems, we bring in a special tailored program. For example, people who are sleep apneic need to have CPAP treatment. People who have cardiac disease, we sometimes alter or adjust their antihypertensive treatment or beta blockade or whatever else they're on. People who have rhythm problems, we get the pacemakers checked. None of these things, by the way, are a reason not to have the surgery. And in fact, I get a lot of referrals now, particularly as the surgery has become more and more advanced, with people from cardiologists who want to reduce the cardiac load in people who have failure, from respiratory physicians who worry that the excess weight is adding to whatever other pathology there is that's making their patients breathless and reducing their functional activity and exercise tolerance. So in terms of preparation, simple things, mindset, make sure you're ready for it mentally. I would say again, you will never get that perfect moment, and you'll just postpone it inevitably. And I have many patients in my books for 5 years, or maybe longer, who make contact every couple of years. They're not quite ready, and I'm just watching them get bigger and bigger, and the diabetes get worse and worse. And I think in those cases, it's hard for us to say, look, you need to have it done. It needs to be patient driven. But you just got to say, well, look, it's never going to get perfect, and I'm just going to get worse and worse. And as you get older, you risk it more. It gets harder. So I think grab the moment when you feel you're ready and go for it.